Oh, yeah, here we go. Good morning, everyone. I think I might be the first person to officially welcome you to the liver meeting, so I have that honor. Welcome to the liver meeting. It is definitely my pleasure to welcome all of you. My name is Matthew Duva. I'm the Chief Executive Officer for AASLD, and I get to work with great people like Michael Providence, who is our Senior Manager of Patient Engagement, and to work very closely with the great board of directors governing board that AASLD supports and guides our organization. So my job here is just to welcome all of you, to thank you for being here. In the 4 years that I've been with AASLD, it's just been a complete pleasure to watch the patient engagement program really grow and really develop here at AASLD and the partnerships that we have been able to create. So I really appreciate that. I really appreciate you being here and being part of the patient program and being part of the larger scientific program. And I just want to acknowledge and thank the many people in the room who are part of our committees and working groups and are adding the patient voice to so many of the AASLD products and services that we deliver, our guidelines, our education, and the like. So thank you for that partnership. Thank you for being part of our advocacy efforts. There's a lot of work that we have to do, and certainly, as the theme of the meeting is, we're certainly stronger together, and your voice is really important in that. So with that, I'm going to introduce Carla Brady, who is the governing board liaison to our patient advocacy advisory group, and is also the secretary of the AASLD governing board.
Thank you, Matthew, for the warm introduction. It is fantastic to see the room so full and to see actually a few people standing in the back. Apologize that it's standing room only, but this is the best kind of problem to have at an annual meeting like this. So I'm grateful for your presence, your attendance, and look forward to this wonderful opening session for today. We're so glad that you joined us. We are looking forward to a session that will be co-moderated by Dr. Sherry Cohen, who I will have an opportunity to introduce to you in just a few minutes. She, as I mentioned before, are my slides advancing? Yep. Okay, there we go. All right, very good. You already heard from Matthew Duva, who is our Chief Executive Officer. Another person who I don't think is quite in the room right now. She's probably at another session, but is also a fantastic member of the AASLD staff. That's Julie Deal. She serves as our Deputy CEO. And she is also the AASLD Foundation Executive Director. She does a lot of work working alongside Mike Providence with the Patient Advisory Group, and certainly has been a champion for the voice of patients, advocates, and patient advocacy groups. Let's see. I also want to take the opportunity to thank our corporate sponsors for supporting this meeting, Intercept and Bergen Ingelheim, who have been important sponsors for the patient program this year. In terms of our agenda today, we are going to just have a few words about AASLD patient engagement and the foundation. We are here today to talk about patient-provider collaborations for education and advocacy in liver disease. This will be presented by Dr. Sue Wong. We are going to also hear from Wendy Lowe about how do I become a patient advocate, and then Ruth Brogdon will also talk with us about the intersection of health care and patient advocacy, and this will be followed by a panel discussion. In terms of the liver meeting itself, this is our 5th annual patient forum. This is an opportunity for us to hear from you as patients and patient advocates. You're extremely important to our community here at AASLD. We deeply value your contributions. your ideas, your collaboration, your voices, your hard work that you put in to helping to make sure that the patient voice is heard and represented well in the work that AASLD has done and is continuing to do. In terms of TLM, or the Liver Meeting 2023, just wanted to let you know that we have more than 150 patients, advocates, caregivers, and patient advocate exhibitors who are represented at this meeting. So I think it's fantastic that we have so many people on the ground here in Boston who are representing the patient voice here at the Liver Meeting. This is an opportunity for you to network with your peers while you're here, to exchange ideas with the leading clinicians and researchers during a variety of different sessions, including this session today and sessions that will take place later on across this weekend. And so we look forward to a really robust discussion as we update you on our progress in terms of research in clinical care in liver disease. In terms of our strategic plan, as a part of the AASLD, we do have a patient engagement wing to that particular strategic plan. And there are 3 key areas that are outlined in the strategic plan that really focus solely on patient engagement. This includes increased patient representation in what AASLD is doing, ensuring that there are higher levels of patient engagement and awareness in the overall mission of the organization, and to ensure that there's a stronger profile and partnerships in advocacy and other initiatives with AASLD. And then just a word about our foundation. Some people wonder, what is AASLD versus the AASLD Foundation? And there's sort of maybe 2 halves or 2 sides to a coin, but they are 2 different entities. Our AASLD Foundation is an entity that has the responsibility for increasing funding for research and career development opportunities for the next generation of hepatologists. And thanks to the support of those who are supporting the foundation, we have the opportunity to invest more and more in hepatology research. And this year, the foundation has been responsible for funding $2 million in research awards that are aimed at both basic and clinical research, as well as translational research for those who are studying liver disease. And so we're really grateful for all those who have made this happen. And with that, I will introduce Sherry Cohen, who's the president of the Hepatitis B Foundation. She will take it from here in terms of introducing our speaker, our first speaker for today.
Thank you, Carla, and thank you everyone for being here today. I just want to take a moment as one of the members of the patient advisory group at AASLD to thank AASLD for the opportunity. I'm actually rotating off the PAG, or the PAG, in December. It's been a really incredible 2 years, and having worked with a number of disease societies around the world, I will just say thank you so much for the opportunity for people, advocates, people who have lived experience to actually make a difference throughout the year in advocacy and policy, but also at the meeting itself. This is an incredible opportunity for clinicians, advocates, and people with lived experience to communicate together and share experiences and strategies. So thank you very much for this opportunity. It is my pleasure to introduce Dr. Sue Wang. Dr. Wang is the medical director for the Chinese medical program at St. Barnabas Medical Center. She's board certified in internal medicine and pediatrics. She received her medical degree from the University of Miami, her master's of public health from Johns Hopkins, and she completed residencies at Georgetown and also was a fellow with the CDC. Dr. Wang is past president of the World Hepatitis Alliance, where she oversaw the launch of the global Hepatitis Can't Wait. I think everybody knows Hep Can't Wait, and that was really Sue's baby. And she's made an incredible difference in elevating the patient voice throughout the world. She's also the global policy advisor for the Hepatitis B Foundation and is incredibly committed to making sure that the voice of the patient is elevated. So without further ado, Dr. Sue Wong.
Sorry, they have to switch my slides. But while they're doing that, I was going to say we've got empty seats and we have some people standing, so maybe if you have an empty seat next to you, move, or let somebody come and sit, since we don't want anybody to leave the session, so. There are like 3 right here. Okay, perfect. All right, good morning, everybody. It's very exciting to be at the first session of the Patient Advocate Track here at AASLD. I love the step here. I feel so tall. They should have this at all of them. All right, so my disclosure, Gilead Sciences research funding to the institution. So I'm really excited to talk about physician and patient collaborations to improve care, liver care, and I'll talk about this on a number of levels, both individual level, the level of improving research and programs, and then on the level of advocacy. And I think this really kind of epitomizes what so many people are doing in this room with the AASLD community. So I love this quote: patients are the largest and least utilized healthcare resource. And I think you guys would all agree, right? And underappreciated, right? So, and why is that? I think this diagram shows the many domains and ways where the patient voice and engagement can have a tremendous impact on how we do healthcare. Some of them are to improve the shape and flexibility of clinical services, optimizing opportunities for participation in research, sharing personal narratives, which so many of you have done, reducing stigma, providing peer support, and promoting investment for government and industry, and improving access to care, screening, and therapy. And so it covers so many domains: communication, representation, investment, and clinical care. So here's another way of looking at it. We have millions of people living with liver disease, right? We think in the US it's more than 100 million people. And a lot of them have not been identified. They haven't been screened yet. And that engagement of patients, and if we can mobilize everybody living with liver disease, energize them, we've got the power of millions, right? In addition to all the financial resources which we need, but the power of millions can actually do quite a lot. So if we can take that activated community, we can increase awareness, demand access, drive advocacy, and when we partner with scientists, researchers, and policymakers, we can make a huge difference in improving program delivery and even combating stigma and discrimination, which we see so prevalent in liver disease. So, and Carla touched on this, and I just love that engaging patients is one of the 6 pillars for AASLD, so we really commend the board for doing that, and I think this just really exemplifies the partnership that we're looking for in a medical society. So I'm going to start with what it means to collaborate on a one-to-one level. So what we were really talking about is having the viewpoint of a patient or person-centered care where clinicians and patients are really working together for the best outcome. So we're no longer talking a paternalistic model, which is kind of an old model of medical care, where the physician dictates all the decisions, but what we're talking about is care that is really respectful and responsive to individual personal preferences, needs, and values. So I think all of us, especially for clinicians, recognize that you can have 2 patients with the exact same clinical scenario, same labs, risk, disease state, and if you present them the options, they will choose different things. And sometimes you're surprised about which patient chooses what. So we should never assume that we know what a patient values, and we should always offer that opportunity for patients to make that choice. So in order to do that, patients really need to have the necessary information and opportunity to exercise that degree of control that they choose over health care decisions. But the goal is really to get to a point of shared decision making. So what does that actually look like? Well, you can see this is like the intersection of shared decision-making, where you're taking a combination of evidence-based medicine, provider clinical experience, and integrating it with the patient values and preferences. So what does that look like, and how would it unfold in a visit? So step one, this is from a clinician viewpoint, seek your patient's participation by communicating that there is a choice and that you want them to be a part of this decision-making. Step two, help your patient explore and compare treatment options by discussing the benefits and risk of each option. For example, and I'm going to use Hep B a lot because that's the world I know, so that's my, just so you know that, but I'll be talking about other disease states too. So for example, if you have Hep B and your labs are kind of borderline in terms of viral load and ALT, the question is, do we start treatment now or wait? Or if you have steatotic liver disease, are we going to start a statin for your hyperlipidemia? Or do you want to be aggressive with your diet and recheck your labs, right? So there are options a lot of times that come up for patients. Step three is then you assess your patient's values and preferences and take into account what matters most to that patient. So for example, with a Hep B case, my Hep B patient may be really concerned about liver cancer and want to start an antiviral now. Or a different patient may say, I actually prefer not to take a medicine, but I agree I will come back regularly for monitoring. And for that steatotic liver patient I just talked about, they may say, oh, there's no way I can change my diet. I love eating too much. So start that statin on me. Or they may say, no, actually, I don't want to be on a med. Let me try to change my diet, exercise, and lose weight, and I'll come back in a couple months. So we do this, and it's important for that the patients to be able to make those decisions. So then basically you've made a decision with the patient and deciding on what's best for them. And then step five is to really evaluate the decision. Is the decision reasonable and there are concerns? If they decide to not go on therapy, you do want to have them have a clear plan for coming back and rechecking the labs so we don't lose patients to care. So next, let's talk about collaborating on a broader level. How do patients and physicians collaborate to engage more people in care and improve the quality of care? So it's one thing for there to be an immense amount of research, which we'll see here in the next couple of days, about a disease state and know a lot about effective therapies and medications that work and great guidelines that experts have worked so hard on. But you have to partner with patients and community for them to actually have impact and for science to have its intended effect and to eventually actually improve care and actual outcomes for patients. And I kind of think of it as the in vivo versus the in vitro, right? In terms of like what you have in the lab, in order for it to actually work, you have to consider like real life issues, which is where the community is an expert at. So we must make sure we're not pursuing science as just an academic exercise, but to really improve the lives of our patients. So our objectives and goals should always look at integrating outcomes that are important to patients. Lived experience, patient-reported outcomes should be integrated into our approach. So I challenge all the scientists and clinicians in this room to work together with patients and communities around you to improve care. Actively seek input from them, co-design your programs where possible, utilize the community as a resource for peer support, recognize that other patients are actually experts about living with the disease. We need a humility in the patient-physician perspective that our expertise as physicians has its limits, and we have to tap into the patient community for their lived experience, expertise. So we need to recognize that there are so many barriers to healthcare engagement and that many patients have problems just even making it to us. So your patient's lack of follow-up may actually be due to insurance, cost, geography, transportation issues, work issues, language barriers, not being able to leave work on because when you see them, when you have office hours is actually when they have to be at work. And of course, stigma is a major issue for people accessing healthcare too. So if we want to improve patient outcomes, we have to adjust how we deliver care in response to these barriers. How do we improve that patient experience, and how do our teams help patients as they navigate their way through a very complex healthcare system, especially in the US? And Ruth's actually going to talk about that team-based approach. So there are ways in terms of increasing access, and I think so many of us have seen telehealth really be revolutionary during COVID and even beyond. I see so many patients for follow-up visits via telehealth, and I can tell they're at their offices, they're at their home with their kids. I have a lot of Asian patients that work in restaurants, and I see them cooking in the kitchen, and they go take the call from a supply closet. So there are ways of, but that person couldn't otherwise leave their work to come see me. And so there was ways of doing this. There's electronic communication. A lot of physicians have satellite sites in suburban areas, so we don't make patients come to the hospital. So these are all really important for increasing access. So, and then obviously integrating services as much as we can, and even small measures like making sure people get mail order delivery of prescriptions that can make a big difference. Simplifying care, obviously, into fewer steps for patients is huge, and if we can enable frontline providers and really task shift to decentralized care to do some of that care, we're going to get more people able to get liver care. And as a primary care doctor, I can tell you the liver as an organ is really neglected. We think about the heart, we think about the stomach, and it just is something that's out of mind, out of sight. And I think that we need to make our guidelines less complex and easier to be implemented in a primary care setting. So what we don't want to do is just wait for patients to develop cirrhosis before we send them to hepatologists. We really need to get more upstream in terms of these diseases. So as part of your health education to patients, for physicians, make sure you're aware that there's so many support group resources out there amongst this room. So many people have created amazing things for patients. These are lifelines for patients to not feel alone and to really feel like they're part of a larger community of people who've walked the way before. So many questions that patients have can be answered by people with firsthand experience, including those complex insurance issues. Being connected is really helpful for people's mental well-being. So for example, Sherry and I are part of this Hep B community forum, and it's really fascinating the kind of messages and questions people have. These are questions that they never ask me as a physician, but it's things that really weigh on them heavily. You know, how do I tell my partner I have hepatitis B? Is this, you know, am I going to be able to pursue the career I wanted to? You know, I'm so afraid, I'm so worried, and these are things we don't often hear about, but it's so important for patients to be able to talk to other people about them. So make sure you offer these, you know, as part of your health education to patients. So we often talk about integrated service delivery, and this has been well done in a lot of areas. I think Hep C has really kind of highlighted areas where we can do co-located services. This is just one center in Switzerland that's a great example of integrated services where you have primary care, opioid agonist therapy, all under one roof, psychiatry, hepatitis care, social work. I think this one even had wound care and general medicine as well. So, for example, at my office, we're not this big, but we do have primary care, mental health, an ambulatory pharmacist, surgery, and derm, and it's really helpful for patients to be able to have all that in one building. So our understanding of disease is also incomplete without the patient experience. So we're going to talk about patient-reported outcomes, or PRO now. And this is just a reminder, we need to focus on the whole person, not just the liver. So living with liver disease is not just what shows up on your blood work or your ultrasound result or what medications you're taking. And it's good to be reminded that patients, for the most part, are not patients all the time. What we see when we see them in our clinic, that's just a small part of their experience, and they have a whole life outside of the clinic. The IOM defines PRO as any report of the status of the patient's health condition that comes straight from the patient without interpretation of the patient response by a clinician or anybody else. So this allows us to see where living with disease can impact the many aspects of a patient's life, not just their liver enzymes. So there are many tools out there. Some of the PRO, or quality of life tools, I've listed here, HRQL, SF, well-being. There is a chronic liver disease questionnaire. And there's some specific ones, like there's a PSC specific one, and then there's ones that look at work productivity and activity. And one of the questions to kind of pose out there is, could PRO be considered like an emerging biomarker in chronic liver disease research and used in clinical trials as endpoints? So here's an example of a PRO that was developed for NASH. It's called NASH Check. I know Donna was part of this and some other folks that are part of the PAG. And this was designed to be used as a clinical trial endpoint. So it was based on literature and patient interviews. They recruited non-cirrhotic patients and looked at symptoms such as pain in the right upper quadrant, poor sleep, memory, or reduced focus. They looked at risk factors such as diabetes, high BMI, and psychological risk factors. And then they also looked at impact areas, which would be activity limitations, social impact, psychological impact, and even economic impact. It's a really nice framework they created. And when they actually use this on patients to ask people to report where living with NASH impacted them, it was really interesting to kind of see the percentage of patients reporting on each of the impacts. So the highest ones being that having NASH impacted their healthy eating choices. Stigma was second right after that. Third was participating in activities. And then fourth was interacting with children and grandchildren. Like, I wouldn't have thought about that, but NASH impacts how people feel like they're interacting with their children and grandchildren. Low mood, and even hiding disease symptoms and impact from others. So for cirrhosis, there have already been a number of PROs developed, and the question often comes up, what can you do about some of these PROs? Like, how would I actually incorporate this into clinic? Like, if I had a PRO survey, what would I then do in response? So I love that this one was a publication about a screening questionnaire, and it addressed areas like muscle cramps, pruritus, itching, if you have problems sleeping at night, problems with sexual activity, and then there were therapeutic options that were offered for that. So different vitamins or creams and sleep hygiene issues. And I think that's something we often don't pay attention to as much. So it's nice when there's a ability to kind of provide some clinical relief from some of these issues. So next we're going to talk about how patients and physicians can collaborate to advance research and practice guidelines. So how do we move from patients as subjects to being more meaningfully involved? We're used to seeing patients as subjects, either of our care or maybe in a study as a study participant, but we want to increase that level of engagement. We can do that in a number of ways. So in research, particularly, researchers could share the information to study participants about directly with the community. Or there could be more of an effort for the research community to share their work, focus more on a community level. And at the highest level, what we have is where patients are actually involved with design, and patients and scientists are working in collaboration to plan, design, manage, evaluate, and disseminate research together. So that's kind of the epitome of patient involvement. So this extends to also patient involvement with development of new therapies. So for example, for Hep B, why are patient perspectives important in the development of Hep B cure? Well, this allows us, by tapping into patients, it allows us to clarify the rationale for finding a cure. Why does a cure matter? It helps us understand if proposed treatment interventions would actually be useful. Is this cure going to have real practice, and are we going to be able to adapt it to the real world, especially in resource-limited settings? It also helps to avoid any unintentional harm to the affected community. For example, we don't want to exacerbate stigma. And importantly, this ongoing communication involvement of patients really helps maintain a trusting and respectful relationship with the scientific community. We know with COVID that was an issue in minority populations in terms of the vaccine. And so bringing patients on early on helps to kind of maintain that trust in the community. So the FDA has actually been doing more of these patient-focused drug development sessions recently, which is great. This is an FDA initiative to obtain patient perspectives on specific diseases and their treatments. For Hep B, this was held by the Hep B Foundation in June 2020, and it was a great discussion with many patient participants. And the goal is that drug developers would then take these views into account as they plan their studies. And I believe after this, there was also a fatty liver PFTT hosted by GLI. And actually, this is interesting. There's something called patient-centric clinical trials, where patients are actually involved in designing execution of clinical trials. These are designed to improve relevance of a study to the patient. By doing so, encourage also patients to participate in trials. So this might impact, for example, inclusion and exclusion criteria, the visit burden. A patient might say, once a week is too often. Can we try remote monitoring? Because we know that can really turn off patients if they have to go in so often. And what is really interesting is that patient-centric trials are more likely to produce drugs that end up going to market, and they are much faster to enroll patients in a trial. So if you can see the different bars, the lighter blue bars represent the patient-centric trials, showing a much shorter time to recruit 100 patients versus the all trials in the darker blue. So this HCV prop-up study was a PCORI-funded study. And it was interesting because within the study, they had a Hep C patient engagement group. They recruited 7 people that were affected by Hep C, and it was a mix of people who've been treated, untreated patients, patients cured, not cured, and patients still contemplating. So it was very diverse, and there was gender and race diversity. So this engagement group developed their own mission, goals, MOU, and scope of work, and they were paid as consultants and viewed as equal partners with full integration into the team. So their first task was to assess which harms and benefits were most important to patients regarding the decision to go on Hep C treatment. So when they asked patients to evaluate the importance of each of these factors involved, you can see they rated all of them as pretty important or extremely important, right? So we're looking at cure rate, side effects, harm to the pocketbook, harm to functioning, harm to liver, harm to other conditions, long-term survival, and then benefits. But then they switched the question. They said, rank them for us. So priority rank it. And then you see the distinctions really come through. Cure rate was at the top, and then interestingly, harm to pocketbook was the next. Not long-term survival. You see that way down here. And yet our studies are always looking at long-term survivals, right? So it's interesting that to a patient, long-term survival is kind of like a distant thing. But in the day-to-day, I'm looking at what impacts my here and now, which is side effects and harm to pocketbook. So switching over, diving a little into PROs, this was a survey done by Hep B Foundation on what patients reported were outcomes of them taking their medicine. The green bars are respondents from the US, and the orange bars are international respondents. So the top 4 outcomes reported by US respondents, the bars in green were, by taking medicine, I'm less worried that I may live a shorter life. I am not, number 2, not worrying about transmitting the virus. Number 3, less worried that I may develop liver cancer. And number 4, feeling good, I am able to manage my Hep B. So interestingly, it was different for patients outside of the US. And so in the orange, these top 4 were, 1, I don't have to avoid others. I mean, can you imagine that? That was the number 1 reason they appreciated being on medicine, because otherwise they felt they had to isolate themselves. Number 2 was feeling less stigma or shame. 3, feeling less tired. And 4, less worried that I may live a shorter life, which, remember, was actually the top reported for the US. So we have to really think about these things, because I don't think we usually assess these. We usually have patients come in, we look straight for their labs, right? And that's what our clinical decision-making is. But there's so many other impacts for patients. So this just kind of goes right into how the psychosocial impacts of living with liver disease really haven't been well studied. And for hepatitis B, there is a lot of fear and worry, which primarily impacts patients themselves. They worry about progression of disease, infecting others, how it will impact their livelihoods. And that the secondary impacts in terms of how they interact with the community have to do with stigma, discrimination, and even healthcare providers. And then the resulting tertiary impact is that this can lead to people feeling silent, being silent, withdrawn, having self-stigma and guilt. This was a survey done globally by the World Hepatitis Alliance looking at Hep B and Hep C. It's interesting, 50% of people reported being aware of other people with hepatitis being excluded socially. 40% reported being excluded at work. 37% had reported knowing of people who have been abandoned by a spouse or family member. And also just those domains here are about patients having hepatitis where it impacted their employment or patients losing their incomes. So if you ask, do you think hepatitis patients want to be cured? Yes, just because it impacts so many areas of their lives. What's amazing to see is that the impact of stigma has been a major driver for changing the terminology for fatty liver. And I think all of you have seen the big news that we've now not using fatty liver. And when you look back, you see this is a publication on the left from 2021 titled Redefining Fatty Liver Disease, and this was an international patient perspective. And it suggested that changing the term non-alcoholic fatty liver to metabolic fatty liver, to metabolic liver disease, associated fatty liver would have at least the impact of reducing stigma, trivialization, impacting health policy, and increase public attention amongst other things. And so what's ensued over the past couple of years is a multi-liver society Delphi process for renaming, and the new nomenclature is now steatotic liver disease with a number of subcategories underneath that. And this was released earlier this year. So what's amazing is this panel consisted of 225 people, very representative societies across the world with ASLD, EASL, LA from Latin America, APASL, and others. And I love that 11% of the Delphi panel were people who are patients or are representing patient organization. That's really something that we should be aiming for in all of these kind of guidelines and consensus statements. So I think, speaking of guidelines, of note, clinical guidelines that are made following grade methodology, which is kind of a gold standard amongst guidelines, actually do have a place where we address values and preferences of patients and acceptability, feasibility, and equity into the evidence of our decision. So this table that's used to kind of judge all the recommendations has, as you see, number 3, values, 5 and 6, acceptability, feasibility, and then 7, finally, equity. And you can see some of these equity questions in terms of like what would be the impact on health equity. And that's something I know ASLD has been addressing too in terms of health equity. So, I think I look forward to us doing more of this in our guidelines because I don't think it's been done really consistently, but this is a good goal. So, and then just in terms of like some of these recommendations, sometimes you see in recommendations with like strong recommendations and conditional recommendations. I think what that means is important to realize when something's a conditional recommendation, it means that amongst the population, the target population, the majority of people may want this recommended course of action, but many would not. And as healthcare workers in response, this means shared decision making is even more important in these considerations to make sure that patients are making decision consistent with their values and decision aids. And for policymaker, it means that it is okay to have debate and to make sure all stakeholders are involved with these discussions. So next we're going to talk about collaborating to increase awareness and education. And this is really kind of talking about targeting a patient-targeted medical education. And I'm not just talking about like, pamphlet about fatty liver, but this is really about how do we make sure medical advances, researches, for example, at ASLD, are actually getting filtered down to the community so people are aware of all the latest advances. So we do need to kind of make research more accessible, either through plain English summaries or even a short sentence or paragraph, which you've often seen, and this is actually standard for HIV publications, that it might say what this means for patients. So this is beneficial for the research community because when you have an educated population, they are then ready for the new treatments, and you have patients asking to be screened or asking to participate. And we saw this with Hep C. There was a lot of awareness with screening and a lot of hype about the DAA. So you had the floodgates open and all these people went to get treatment. And so we need that definitely for Hep B. This is an example of a community forum that happens every year at the International Hep B meeting where there's a session that's dedicated to providing the latest research to the community, and it's open to the public. So in ASLD, if you have not seen this on the website, there's some really, really great patient-friendly guidelines. So basically, this is a list of which ones exist right now, and they've been rolling these out periodically. And they're written specifically so patients can understand the guidelines that their physicians are using. So the clinicians can provide these during the consultation. And the message or the guidance itself is unchanged, but it's just done in a way that's easy to understand. And even has these cute little diagrams. And this one was designed by, many of you know Nancy Rowe. This is her daughter's art. That's very cute. All right, so other patient resources online, if you haven't checked the ASLD website, a lot of webinars, educational videos. Many of you will remember during the height of COVID, there were so many questions and concerns that patients had. And I think we did a really great job addressing it. Here, Karen Hoyt was a moderator. And we had so many things that were kind of delivered directly to the patients. So we look forward to doing more of that. And of course, it's clear that patient stories are really compelling and often have much more of a profound impact on people than all the facts and research that we have about a disease. I mean, how many people go for a mammogram because somebody they know had breast cancer, or colonoscopy because they found out somebody had colon cancer? People also develop much more empathy and awareness about a condition when they have a firsthand story. And that's why it's so important for us to continue to showcase the stories and get these messages out. And for all of those of you who have been part of this, this has been, we commend you because it's brave to go out there in public with your story, but it makes a difference. So finally, I'm going to talk about collaborating for advocacy and policy change. It's obviously a super powerful combo when we have patients and clinicians partnering together. I think sometimes providers don't see themselves as advocates. They kind of think that's like what these other people do. But it's really important for us to really be champions wherever we are. So it could just be your practice, your hospital, your healthcare system, and just to be able to voice some of the stories that you hear from your patients. And I would challenge that all physicians really try to join forces with patients and patient groups and their community organizations. And this little meme here, I love this. It's like kind of an emoji depiction of evolution of a physician activist. I think it usually starts when we're upset about something. You're upset about something you feel like was unjust. This is like evolution, anybody becoming an activist, right? You see something as tragic that shouldn't have happened, you start getting mad thinking about it, and then you get more and more fired up to the point where you want to do something to make that change, right? And a lot of us have gotten to that point because of that wanting to fight injustice. And so I think when that does happen, you join forces with people, patient groups, and other organizations like medical advocacy organizations or ASLD when we do Hill Day. And I think there are some really practical ways of dismantling the barriers that we see patients have. So I heard of physicians like joining formulary boards of their state to make sure our meds are covered, or even giving medical testimony to legislatures. This is a No HEP guide, which actually talks about exactly what it is that physicians can do. A lot of it is really just educating peers, raising awareness, and just being vocal. So these are just some examples of some amazing milestones that we've seen on liver advocacy in the US. Obviously, the National Hep C Elimination Plan, and there's a session on Friday, today, 4:30, right? So make sure you come back for that. And there have been, besides the National Elimination Plan, also a lot of successes in different states. And a lot of efforts to change certain issues. So obviously the restrictions on Hep C DAAs were a really big issue. And so the Center for Health Law and Policy developed this report card, which assessed Medicaid access. And this is a really important tool for advocacy. And then for Hep B, we're in the middle of our own crisis where Vemlidy is being dropped from formulary after formulary, and we really need to put the pressure on insurers to change this policy. We're having so many patients that suddenly find out they can't get their medication, or every month the doctor's office has to go through an onerous prior auth process. Stigma and discrimination, specifically for Hep B, has been a real issue, and where advocacy has also made a big impact. 2 students, medical students who were about to start in New Jersey, tested positive for Hep B when they were doing their pre-employment physicals. They received letters that they can no longer matriculate to med school, and these letters actually said they were a danger to themselves and others. And so they basically lost their acceptances. The Department of Justice was brought in to investigate, and CDC also had convened a group to update their guidelines to be very explicit that people with Hep B could pursue healthcare careers and should not be discriminated. And in 2013, Hep B became officially protected under the ADA, and a letter was sent from DOJ, Department of Ed, and HHS to inform all the med schools. But yet, Hep B Foundation still gets at least 20 to 30 cases a year of students or professionals who face discrimination. And it's a broad range of people, not just physicians, but also nurses, x-ray techs, PT, ultrasonographers. Besides schools, we've seen a lot of discriminatory practices in the U.S. Armed Services. Hep B Foundation also been working closely with the Department of Defense on their policies. And as we kind of talked about drug pricing, so adverse drug tiering we see a lot, right, where insurance will basically take medications and put them in a higher tier so that they're harder to access. And what we found with Hep B is that, we only have 3 oral meds available, and all of them were put into high tiers. And we believe this is a form of disease discrimination, especially since Hep B is covered under the ADA, and the Affordable Care Act has a non-discrimination provision on that. So these are things we have to continue working on. You see there's lots of work still to be done, so I'm going to leave it at that. Let's continue growing these partnerships between physicians and the affected community. Let's fulfill that vision that patients have increasing visibility at meetings like this. This is a photo of the No Hep Village at the Global Hepatitis Summit, where the community was really celebrated in the exhibit hall. And here's a photo from 2019 in Boston when we were here. And we had a freeze mob right in front of the Heinz Convention Center to try to really bring awareness to dismantling barriers to hepatitis elimination. And I think it's important for us to realize we're kind of being megaphones for each other. Patients can be a megaphone for providers and kind of expanding awareness about all the work that providers are doing, and vice versa, providers can really be a megaphone for patients. And together we can really make progress improving care. So thank you for your time, everybody. That's the cost of having the staff.
That's the problem with the staff.
Yes.
We'll try to be really careful. Thank you, Sue, for that wonderful, wonderful overview. We'll move on now. So I'd like to take this opportunity to introduce our next speaker, who is Wendy Lowe. Wendy Lowe is going to be talking to us today about how do I become a patient advocate. She is a patient herself who turned into an advocate for hepatitis B elimination and liver health. She shares her lived experience to increase awareness, promote education, tackle stigma, influence policy, and support research. She is an educator and a wellness coach. And in her 20-plus year experience in the Silicon Valley, she is a high-tech professional whose work falls at the intersection of education, technology, and innovation. She's held a variety of positions in education, program management, and information technology, consulting at various software companies. She holds a Bachelor of Arts degree in Political Economy of Industrialized Societies that came from the University of California, Berkeley. Wendy resides in the San Francisco Bay Area with her spouse, 2 children, and a rescue dog. So I'd like to welcome to the podium Wendy Lowe.
Is this showing? Okay. Just get set up. Do you recall a time when something happened to you that changed the trajectory of your life? Perhaps you didn't know it then, but looking back now, you can see that it was consequential. For me, the year was 1994. I was a senior in college. I was getting ready to study abroad in China, and I went in to get a medical screening. I found out I tested positive for hepatitis B. I graduated, but I did not study abroad. My dream to launch a new venture in China was crushed. I was originally born in mainland China, and I immigrated to and grew up in San Francisco. I was transmitted hepatitis B at birth, from mother to infant, which is most common. Hepatitis B causes inflammation and over time can destroy the liver. I'm really honored to be here to talk about this topic. How do I become a patient advocate? I've organized my talk into 2 parts. 1, my liver story, my experience of living with hepatitis B. And 2, becoming an advocate, why I got involved, what are some ways to engage. By liver, I'm not just talking about the organ. So this is not just a medical story. I'm talking about the person who's alive. You, me, all of us here. It's a person-centered story. It's a holistic story. And one more thing, I'm here to share my story here. What I invite is for you to engage and reflect on your own experience. If I were to organize, if my story is a book, here are the chapter headings by decade after my diagnosis. In my 20s, I was told to monitor. There was no treatment available. I did for a while, and then I stopped. I didn't have physical symptoms. What was really top of mind for me dealing with hepatitis B was drinking, dating. In my 30s, I started medication right when I got a checkup. This is also the time when I started a family. As a mother with 2 young kids, I would worry. I worry because I know people die in their 30s and 40s. So that's when I prioritize to start living a healthy lifestyle. In my 40s, I would characterize it as things falling apart and then putting it back together. I have a loved one who was in decline because of liver cirrhosis and passed from liver cancer. This is also the same time when I was diagnosed with liver cirrhosis. Then you add in other life challenges and other things that get in the way. That was the perfect storm to create a tailspin for me. Luckily, I got help for my mental health challenges. And today, I can say I do not have liver cirrhosis. Throughout these years, decades, I've been living with hepatitis B in silence. I experienced fear, shame, isolation, and self-stigma. In 2020, something happened. I attended this global event that Dr. Wong had talked about. I heard from a few Just Be storytellers, watched their videos, heard about their lived experience. This was the first time that I connected with others. They're going through something similar to me. I didn't know these people, but yet I felt so connected. For the first time, I did not feel alone. Wow, the gift of another story. It resonated with me so much. I felt heard, I felt seen, I felt acknowledged. I was not alone. This was a powerful experience that stayed with me. So fast forward to last year, 2022, I became a Just Be storyteller because I wanted to pay it forward. My plan was to create this video, put in some old pictures of me, toss it over the wall to the Hep B Foundation, and let them do whatever they want. I can stay anonymous. No one would have to know. Little did I know that this would be my springboard into advocacy. Last year on World Hepatitis Day, I was invited to speak. I stood behind a podium just like this, in front of a live audience and people watching virtually. This is how I'm feeling in the moment. I remember it well. As I'm speaking, I'm hearing the words that are coming up for myself. There are emotions that were stirred up. They've been pent up for so long. I was so nervous. I had the mic. I was shaking it like a maracas. I had to use my left hand to steady the mic. This was not just nerves of public speaking. Right in this moment, I am sharing my hepatitis B status publicly. I never thought that I would share this part of me. This part of me. This part of me that I felt a need to hide. I did manage to hold my composure, just like this, and get through it, because the audience is with me, like you are right now, being present, listening attentively, and just holding a kind space. It was a cathartic experience. Something was loosening inside me. It's like candle wax that's been hardened and stiff, yet can soften and melt with warmth. You know what? I gained 3 ahas, insights from this experience. One, when I step out and be vulnerable, growth happens at the edge. 2, personal stories. They benefit me, the giver, in addition to the receiver. And 3, something magical happens. Storytelling is a powerful way to connect, to express who we are and what makes us alive. Brené Brown, author of Courage, Shame, and Vulnerability, she puts it this way. Maybe stories are just data with a soul. Everyone has a story to share. So take a moment, reflect, what's coming up for you? Let me now segue to talk about advocacy. I use the word becoming because I really relate to it as a process rather than a destination. I also find it useful to frame it on a continuum for 2 reasons. One, in part to acknowledge that in some way I'm already an advocate. When I look back, I've been advocating all along, from researching the chronic condition, learning how to reinterpret the labs, navigating the healthcare system, getting a second opinion, and being a health seeker. These are all examples of self-advocacy. And 2, it's important to recognize we are not stationary on the continuum. This is dynamic. There will be times that will move more to the left and other times more to the right, depending on a lot of things, including our health condition and what else is going on in our life. So let's talk about public community advocacy, stepping to the right, and why. There are lots of ways to engage, and I'm going to offer a few examples. We can volunteer in the community at a local level. This is a great way to meet and connect. Or do it virtually. You can participate in clinical research and development, such as clinical trials, FDA listening sessions, or join a community advisory board. Provide the patient perspective and voice. Another important part is to advocate and influence public health policy. We can talk to members of staff on Capitol Hill, organize and sign online petitions, and join coalition meetings, events. One thing I'd like to invite you to do is to explore and identify where your talent might meet an unmet need. So when I found out that 1 in 12 Asian Americans are living with chronic hepatitis B, I decided to get involved with the San Francisco Hep B Free to do outreach to the Chinese-speaking population. It brought a lot of joy for me to use my bilingual skills and to relate to the immigrant experience. Just last week, by Zoom, I was actually speaking to a group of Chinese-speaking immigrants who are newcomers in Melbourne, Australia. Wow, I just felt so connected in this global village. So Dr. Sherry Cohen had said something to me once. She says, "Wendy, as a patient, you bring expertise." I'm like, huh? What are you talking about? How can I bring expertise? I don't have a medical degree. When I see a hepatologist name and you see the alphabet soup that trails it, I have to Google to find out what they stand for. Yet, what she shared with me stayed. And as I got involved and more engaged with talking to different stakeholders, I come to understand what she is talking about. No one else is in a better position than the patient to be living with the disease. You see, patients bring the first-person perspective. As patients, we're like the fish in the pond. We're swimming in the pond all the time. Others might come, observe occasionally, perch by the rock. But when a pebble drops into the pond, others might see it fall in. We feel it. We experience the ripples and its aftermath. And we may be aware of what's happening beneath the surface, in places where others are not even looking. Patients bring something we already have, our lived experience. To put this another way, everything that you've been through contributes to your expertise. And to be more precise, what we contribute is informed by our lived experience. I'm talking about our perspectives, our preferences, our insights, and our wisdom. We contribute in a unique way. Patients provide data with a soul. So share your expertise. Tailor what you share depending on the stakeholder audience. This nuanced way of sharing is how we turn our lived experience into impact. This is how we step into our power as patient advocates. Now, I know it can feel vulnerable to share. Here are 3 tips that I give to myself to safely embrace vulnerability. 1, proceed at the speed of my readiness. It can feel emotionally taxing to share, so practice self-care. The aim here is to stretch, but not tear. Set up healthy boundaries, especially when it comes to disclosure. You decide what to share, how much, when, to whom. And just be okay that this may shift over time. And 3, we are stronger together, the theme of this conference. So surround yourself with a support system and offer mutual support. Now, this talk is not complete without a why. So my why, the reason I got involved in patient advocacy is hepatitis B is a marginalized disease. Simply put, I feel compelled to break my silence. So let me unpack this. There's a huge gap in the US for Hep B care. This study shows about 2 million people living with hepatitis B. Less than a third are aware. 15% have linkage to care. 4% are getting treatment. Hepatitis B is underdiagnosed, undertreated, and still without care. When I see these numbers, I actually see my story. Knowing my hepatitis B status has been consequential. Because I was diagnosed early, I can get treatment when I need it. My family have been vaccinated and protected, but many, many are not so lucky. And when we zoom out into the numbers globally, it's worse. Here are numbers from the CDC. There are about 296 million people living with hepatitis B. If you do the math, that's about 90% of the US population. Despite it being preventable and treatable, 820,000 people are dying every year. And I've seen numbers that put it close to 1 million. 1 in 4 are at risk for liver cancer. And based on my own lived experience, I think hepatitis B have two sides to its silence. There's a silence due to the asymptomatic disease progression. The other side is the psychosocial harm. People don't talk about hepatitis B because there's this conspiracy of silence. That is exacerbating the harm, keeping people away from seeking screening and treatment. So we have to include both sides. So when I look at the gaps in care, the global prevalence, and the psychosocial harm, and here I stand at a unique intersection. With what I have, a privilege of receiving care, and with a heart wanting to help, I just feel compelled to say and do something. This quote sums it all. If you can speak, you can influence. If you can influence, you can change lives. So, if what I've shared resonates with you, then join me and step to the right in public advocacy. If you work with or you know of someone who could relate to this, encourage them to step to the right in advocacy. And for many of you here who have been doing this public advocacy for quite some time, thank you. Thank you so much for paving the path. One thing is clear for me. There is no endeavor more purposeful, fulfilling, and noble than to walk on this path together. Thank you.
Okay, excellent. Wendy, that was so powerful. Thank you very much. Thank you for sharing your strength, your wisdom, and your vulnerability. It is my pleasure and honor to now introduce Ruth Brogdon, who is she is the Director for Public Health Programs and Grants at the Center for Asian Health at Cooperman Barnabas Medical Center in New Jersey. And she manages clinical and community programs in viral hepatitis, as well as programs addressing health needs and disparities of the Asian American community in New Jersey. She currently manages both hepatitis B and C automated screening and linkage to care programs and works with Central Navigation Team to make sure that people are getting screened, linked to care and treatment. And she's going to talk a little bit about her experiences in that area. It is my pleasure to introduce Ruth.
Good morning, everyone. So I have to share that in July, I got to share the stage with Wendy. And after I heard her speak, I said, Boy, I'm glad I did not speak after her. So, there goes karma, right? So I'm going to just shift gears a little bit today and on the topic of patient advocacy, talk about advocating and supporting our patients in the healthcare setting. As an overview, what I'd like to do today during my discussion is to talk about a multidisciplinary, team-based approach in caring for our patients and the growing evidence for that. And in doing so, using that team to identify a patient and community's disease burden. And once that is identified, advocating to fill that gap as a healthcare need in a healthcare system that I work at, with using the multidisciplinary program in identifying, designing, and implementing the program, as well as I would like to just end with some examples of that. So there is growing evidence that multidisciplinary team approach leads to positive patient outcomes versus our traditional physician-centric approach. And the positive patient outcomes include increased patient satisfaction, decreased cost, decreased hospital utilization, and also increased provider satisfaction as well. This is a shift from our traditional physician-centric approach where the bulk of the relationship and conversations are between the patient and the physician, and it is more so reflective of this diagram that I have here, where the patient is now the focus, and the patient is having those conversations and inputs with the multidisciplinary team. And the multidisciplinary team, it's important to note, is not just clinical, but can be non-clinical as well. It starts with our patient service representatives that answer that first phone call with the patient, who then may be turned over to our navigator who understands those issues of transportation or insurance. And then finally, obviously, with our clinical team, that is our medical physician, our behavioral health therapists, our social workers. And it's important to note, because this team is, for the most part already there, it does not mean that we need to hire a number of individuals. It's just a shifting of the work and responsibilities across the team. And what this does do is decrease the time commitment by physicians, so the result of that is that physicians also report back less of a burnout. And with this multidisciplinary team, we have an ability to coordinate interventions across the disciplines and expertise. And as I said, we're expanding the roles of lay healthcare workers. An example of this came with the design of our viral hepatitis elimination program, where it started with those individuals, those workers that were focused on disease prevention and health promotion. And those individuals became involved with looking at the community and the community need at our hospital. So the hospital I speak of is Cooperman Barnabas Medical Center in Livingston, New Jersey. It's close to a 600-bed hospital in an affluent area, suburban area in New Jersey. We are one of 12 hospitals of the largest healthcare system in New Jersey, and that is the RWJ Barnabas Healthcare System. New Jersey is a small but mighty state when it comes to diversity. We have 1/3 of our population is foreign-born, and it has the 4th largest Asian American population. And we do know that with Asian Americans, hepatitis B is a high risk factor. So there's an opportunity there considering those demographics. And in terms of hepatitis C, we know that those with acute infections do not necessarily clinically have evident illness, so they may not be seeking out medical care. So we don't know the true incidence of hepatitis C. So that's where complex epidemiologic modeling comes into play, and by doing that, we estimated that the new cases in New Jersey could be as high as 2,000 cases per year. In addition, we also saw that data coming out of our cancer center at Cooperman-Barnabas Medical Center there was a disparity between our center and nationally. Nationally, 16% of liver cancer patients are diagnosed at stage 4. But however, at our cancer center locally, close to a third of liver cancer patients were diagnosed at stage 4. And why is that? Why are patients getting diagnosed late? Well, they were not being screened for conditions that can lead to liver cancer. Hepatitis B, fatty liver, alcoholic cirrhosis. They were just not getting the care that they needed to address this. So, looking at this data, bringing in our medical director, champion, we took on a multidisciplinary approach in just designing the program. We needed to bring in clinicians and understand the workflow. We needed to know how can we implement this screening so it doesn't interfere with the workflow. We needed to understand where nurses would come in, where physicians would come in, where phlebotomists come in. How can we program this automated screening program? So then IT got involved. So that was the design part. In terms of the implementation and launch, we were working with our marketing team, our promotion teams. And here you can see an example of our flyer that we had put out, and that was very similar to the advertisements that were on our TV screens in the emergency department. We had to spend a great deal of time working with our patient registrars and nursing workforce through huddles and education to explain and introduce them to the program, that this program was happening. You as registrars, when you are taking someone's information in terms of their race, country of birth, or age, is going to be the key factor as to whether they would be considered for this screening program, because this was part of the screening. This would all feed in to the screening algorithm. And then consequently, at bedside, when nurses were there or phlebotomists were there to draw blood, there was an opportunity there for them to educate patients and support them there. Once a patient was determined to be positively screened, our navigators would get an alert, and that's when they would then link our patients to care in the clinic. And so then we then shift then to our multidisciplinary team at the clinic level, the patient service representatives, the medical assistants, and of course, the ambulatory pharmacist and clinicians. So this gives you a nice overview of the handoffs to, again, our multidisciplinary team. We start at registration, collecting information, which launches our algorithm and determines if the patient is eligible. Nursing will get an alert if the patient is eligible. This gives, and we also in our EMR have prompts and opportunities to print out frequently asked questions. So if a patient asks a question, the nurse can print it out and provide education and support there. If the patient does screen positive, our navigators get a real-time alert, at which time, again, they reach out to the patient, providing education and support, and then can directly schedule them into our clinic in Florham Park. And again, support, navigation, hearing what the patient's issues are. Once they get to our internal medicine practice, the internist does see the patient and evaluates them for viral hepatitis. We determine a care plan, and then the pharmacist comes into play. Pharmacist is key in attaining those approvals for medication and delivery of the medicine. This is all rounded out very nicely by a care team that meets bi-weekly. So this is all those members that I just mentioned discussing the patient's case, making sure that the patient is following up with their care, coordinating their visits, ensuring that they're getting their lab work done, and adhering to their medication. So out of that viral hepatitis screening program, we obviously had a need for patients to come to the clinic, but we also saw that there were patients that were also being diagnosed with higher acuity cases and needed more specialized services. Also, we had team members see that there were referrals within our medical group system for hepatology services. We also saw that geography-wise, we didn't have those services in our location. And a lot of our patients were forced to go to New York City. That becomes a travel issue, transportation, and also wait times as well. So we then advocated within our healthcare system to establish the Liver Center at Cooperman-Barnabas Medical Center, where we can address these chronic liver diseases and add on to our primary care services with hepatology services to address metabolic-associated fatty liver disease, cirrhosis, alcoholic liver disease, and even serve as a consult for liver transplant. This is a virtual center which connects all the different network services at Cooperman-Barnabas Hospital's network. We loop in a hepatobiliary surgeon, our radiology department, interventional radiology, radiology and oncology, cancer services, traditional viral hepatitis services. We also have the pharmacist, as I mentioned, and also nutrition services for those patients who are recommended lifestyle and dietary modification. We worked with our hospital in the Newark area to then have a cooperative agreement where Dr. Nicholas Persopoulos, our hepatologist, came into our outpatient clinic biweekly to serve these patients. So bringing it now down from the hospital to now the clinic level, we at pre-visit see many different touch points of different staff members who are helping to advocate and support for the patient. And again, it starts from that first call with the PSR, where they're taking the call, assessing the patient and what their concern is, what the diagnosis is, what the purpose of the visit is, helping them navigate through the healthcare system. What health records would they need to have for that first initial visit? Sometimes it actually is talking through and seeing, are you actually calling the right service? You know, do you need to see a hepatologist? Do you need to call the transplant center directly? Do you need to see a GI? So spend some time with that. At the actual visit, that's where our medical assistants are coming in with prepping for the case, getting a history, medication, and our provider rounds it out with their visitation and patient education as well as care. The patient is assessed and planned forward in terms of their follow-up visits with the collaboration now of this medical team that I spoke of. They're determining if there's additional services that are needed, if they need a consult with the hepatobiliary surgeon, if it was a higher disease acuity and they may need additional care. Can they be seen outpatient, or do they need to be seen inside the hospital? And making sure that those additional assessments are all gathered and collected. So patient support and individual advocacy most of the time is done by a non-physician. It's done by the PSR. It's done by the navigator. It's done by the MA. And they have that opportunity sometimes to hear things, as Dr. Wong had mentioned, that maybe the physician doesn't get to hear. They are serving there in terms of questions and answers, education, referrals. They just, you know, honestly, they serve at times as the liaison between the provider and the patient. The provider has their, you know, set 15, 20 minutes that the EMR allows them to see them. And in that, all those concerns cannot be translated. So that person, you know, whether it be the PSR or the MA or the navigator, even the program manager sometimes, they may triage concerns, navigate that patient, and just serve as that communicator between the provider and patient. The team is also integral in making sure that the management of the patient is ongoing in terms of keeping a patient registry, making sure the patient is being seen for follow-up appointments, they're getting their blood work done, there's no issues with insurance or pre-authorization to get a FibroScan done or any other advanced studies. And also they're always taking those calls to make sure that you know, the pharmacist is refilling their medication so they can adhere to their program. So as you can see, it is, you know, from the hospital level down to the clinical level, we have employed a multidisciplinary approach with our patients. And I just want to share 2 cases that I was involved in at the Liver Center that, you know, I helped in terms of navigation as well as social support. There was a patient, he was a 33-year-old male, and he presented with elevated liver enzymes as well as evidence of a metabolic risk syndrome, as he was also had diabetes and hypertension. He was an adult male, 33 years old, living with his mom, single mom, who worked shift work. And she just didn't have that flexibility to come to, doctor's appointments all the time and the doctor's appointments that he needed. And you could tell she was very overwhelmed. And working with the hepatologist, there were a lot of canceled appointments, and there was a lot of workup, and it was a couple of years until we got to the point where the doctor said, the next step is we really need a liver biopsy. There was a lot of questions. There was a lot of fear. The issue of, is it going to hit my pocketbook, came up. And I will say that I was involved in a very tense conversation between the doctor and the patient, and because the doctor was giving up a little bit. And it took some time to just kind of understand the situation and talk to the mom separately and help her stand in her shoes a little bit, stand in her place, talk to her and help her just step by step take those steps to just get that liver biopsy, what she needed to do to get the liver biopsy, and what next steps would happen. And sure enough, 2 years after the patient did get the liver biopsy, did get the next steps and assessment. And she said to me, "Thank you. I appreciate you just taking the time to step out and help me go through that." Another patient was a 67-year-old male who was diagnosed with cirrhosis, well compensated, and he was undergoing hepatocellular carcinoma surveillance with ultrasounds and AFP draws every 6 months, and he was just on this every 6-month visit with the hepatologist. He was diagnosed with fatty liver, was given, dietary and lifestyle modification, and sent on his way. I dealt a lot with his wife. She was the primary caregiver of him. And then unfortunately, on a Friday summer afternoon, I get a call from her saying he's in the hospital, he's in urgent care, he's been diagnosed with a tumor in the kidney. And it's also a diagnosis of ascites as well. And he's not doing well, he doesn't look good. And he obviously was, and he was sent to a critical care unit at one of our local hospitals. He was in care, but she really wanted to connect with our hepatologist. And she didn't know how to connect with him because now there were 3 hospitals involved. There was our center, there was the hospital that he was in, and then there was the hospital that the hepatologist was at. And she just called, and she needed reassurance that the hepatologist was looking at his case because she felt comfortable with that, and he was being seen by this hepatologist in care. And that was just a lot of, okay, I'm going to spend Friday afternoon at whatever, 3:30, 4 o'clock, just making calls and connecting to the clinic at Clinic A and connecting to the ED at, Hospital B and connecting to Dr. Persopoulos and then talking to her. Unfortunately, the patient expired, and I came to know only because a gut reaction was I needed to call the wife. And I called her, and we talked through, obviously, everything. And she just shared with me that she very much appreciated that that Dr. Persopoulos and myself were involved with her husband and that we were very caring. And it was just a social support question, and she, indicated that that meant the world to her as much as the expertise that Dr. Persopoulos had given. So my point of all this is to say that we all have a role, whether we're clinicians with that alphabet soup after our name or not. We do touch patients and have those opportunities for multiple touch points with patients. So in summary, I just want to say that clinical and non-clinical partnerships are important in identifying the needs of a patient community and designing those programs that are consistent with the person-centered medicine. It is so important to continue the collaboration and teamwork in the clinical setting from the initiation of visit to the discharging of case. And we know that this multidisciplinary team approach does lead to better patient outcomes, increased patient satisfaction, increased physician satisfaction, decreased hospitalization, and cost savings. Thank you.
Thank you very much. We know we're up at time, but is this room open for a little bit? We have maybe 5 minutes. So let's do 5 minutes if anyone has any questions that they want. There's some mics in the middle of the room. And then once we disperse, I'm sure there will be time to ask additional questions over the next few days.
Hi, I just want to say thank you very much for everything. I feel very fortunate that I have an excellent medical team, but I am with some American Liver Foundation support groups online, and I hear many, many questions over all, a lot of them, they can't get access to care. I mean, I live North Central Mass, so this is my backyard, and thank you for all your presentation and all your work, because everything is excellent and all that is so much needed. So thank you. Nice to see you.
Thank you.
Thank you. Also, I'm a patient. I was a lucky recipient of a liver transplant at Beth Israel. And I related to a lot of what you said, and I would like to be an advocate, but I had cryptogenic cirrhosis, so there is no organization that deals with someone like me, because I was followed for 10 years by another hospital in Boston who kind of dropped the ball. And I felt very alone. I got diagnosed during COVID, and there was one of the things that has to be stressed is the need for emotional and mental care. And post-transplant, you go in and you feel horrible, and the doctors say, well, your blood work looks great. And you're like, yeah, so what? Yeah, my liver feels great, is great, but overall you feel horrible. And the mental anguish that one goes through having liver disease, and even though I had cryptogenic, I still had healthcare people, when they would say, like, ask me if I drank, and I go, no, but you did. And even healthcare professionals said that to me. And I was like, no, I didn't. So I felt like I had to defend myself. Even if I had, what difference did it make? So I think there needs to be an awareness that the mental side of this disease is ignored many times.
Got some women here who have some, who you should connect with afterwards.
Thank you. So I just, again, I related to a lot of what you said, because I had all of that. And it was very scary. So thank you for talking about it. I wish there was like a cryptogenic cirrhosis thing, because I don't belong in any of those categories. And I wish but I still suffered. Thank you.
Your post-transplant is so good. This is a Zoom meeting that's held twice a week, and everyone's invited.
I have a question. I'm with the Foundation for Rare Pediatric Disease, and we're noticing a massive disparity in outcomes based on the patient's family's ability to get into a trial, their ability to travel, and we've had a lot of success. I think our family flew to California for our daughter to get into a trial, and we were lucky to be able to do so. We've had a lot of success with the team approach that you mentioned, thank you, where a small regional doctor will team up with a trial doctor. I'm in North Carolina, and Charlotte services half of the state. I've got one patient in Asheville who's now driving to New Orleans to see a specialist there, but the system isn't always for that, so I was curious as to what the panel thought and whether you had some success stories on that vein.
I mean, it's kind of similar to what we've done in terms of like creating a satellite site for a physician, because people don't want to go to these large tertiary centers. But I think where you're talking about is even more interesting in terms of pairing up a specialist with it's a little bit like the ECHO program, I feel like, right? Carla, I don't know if you've seen it happen. I mean, you're North Carolina.
Oh, hey. I'm in the other half of the state at Duke. Yes, I agree with you, and I agree that pairing sounds a lot like the ECHO program, which if you're fortunate enough to be in a place where you have that opportunity, then that's great. But, this does raise the importance of the awareness of clinical trials and just access to care in general. I was in a conversation, I'll just say this very, very briefly, but I think it's a poignant point, that I was talking with a fellow physician who has a family member who is struggling with mental illness. And part of what was said to me in the conversation was just how grateful that person was because they were so well connected and had access to care. But that was part of the privilege of being so heavily connected to the healthcare society, and the individuals who had the resources. And so I think more effort has to be put toward extending access to care in all of the other many ways in which it can be done. It cannot always be done in the virtual space, because if you don't have an address, if you do not have a cell phone, if you do not have internet access, then virtual care does not work for you. And so it is clear that there are going to have to be ways in which we have to sort of imagine and reimagine ways to extend access to care to people and ensure that folks have those resources. I think it's important that word of mouth is as effective and as forceful as possible, and that patients know that, hey, there are clinical trials available. Let's find ways to, ensure that you have access to that. And hopefully, maybe one day, someday, that can be built into the cost of clinical trials, capacity to be able to extend those resources to other people and ensure that they have the capacity to have their travel and their lodging, their food, and so forth covered.
Thank you.
We have time for one more quick. Yeah, one more, because we're pretty late.
Thank you for the time. So I'm not from a medical professional background. I'm actually a failed software engineer. And Wendy, when you mentioned software, I thought, I'm going to come up and ask this question. So I don't want to tell the company I represent because I don't think that's appropriate. But a bit about my personal experience. My dad's suffering from Parkinson's, and early stage detection was really kind of key, and that got missed. And why I'm standing here, I'm wondering is we've all been talking about early identification, about monitoring, about things that are missed. I'm wondering what, from people like me from a software background, could do to help, because I do think software has the potential to change the world. And I think there's a lot more education, there's a lot more awareness, there's a lot more personalization that could come through. And I would just be interested in ideas about what software teams like mine could do to help.
I would love to have a chat, maybe offline, just to
Coffee.
brainstorm. Yeah? Yeah, because we're a little out of time. But yeah, I would love, sounds like great.
I would say I think we need more patient-friendly digital platforms like apps and things for people. So I think there's a big room, I feel like so many other fields are far ahead than medicine. So yeah, we could use your skills.
Yeah, no, and I just think it's not complex. Don't get me wrong, it's relatively easy things that could be done that I think gets missed. And I think if I was being critical of the industry that I represent, I think the focus is too much on the science. I think it's too much on the metrics. I think it's too much on that. And then the actual impact gets missed. And that's kind of really what I was bringing it up about. So Wendy, if it's okay, we'll connect and we'll have a conversation.
You have a whole new research area. Thank you very much. I just wanted to close out today. Thank you for your patience. Thanks for staying. Thank you to the speakers and to all the people. Have a wonderful next few days, and we will have plenty of time for engagement. Thank you. Take care.